Welcome to Boston Children's Answers Parentcast. I'm your host, Jennifer Arnold. As a doctor and a mom, I'm passionate about helping kids stay happy and healthy. So join me as I chat with other Boston children's experts to find answers for you and your family. Welcome back, and thanks for joining us today. We have a pretty tough topic today, and that is the loss of a child. It's something that no parent should ever have to go through, but it's an important one for all of us to learn how to comfort those that may be affected. Here to start us off today, as always, is a question from one of our listeners.
Hi, I'm Ryan. My wife and I lost our beautiful son this year to SIDS, and I just don't know how we're going to be able to move on. Can you help?
Thank you, Ryan. First, I'm so sorry for your loss. But today we have someone that I hope can help, Dr. Richard Goldstein. He is director of the Roberts Program here at Boston Children's Hospital. The Roberts Program is a program to help families who have unexpectedly lost a child. Dr. Goldstein, thank you for being with us today.
It's a privilege.
I want to start off like I do with all of our guest experts and learn from you how it is that you got into this field of medicine.
I'm from a small town, and I volunteered in the emergency room. And one morning, a baby came in, ambulance with no sound, but the lights shining, and a very quiet procession across the emergency room. And it was a SIDS case. And I didn't at the time even know that children could die. And I had for sure never seen such despair in a parent before. And it was an important reason that I went into pediatrics in the first place. But it was only when I was practicing in the community that I saw that there are opportunities to get involved. And I became the director of the Massachusetts Center for SIDS. And then I came to children's, I was practicing palliative care, and a researcher named Dr. Hannah Kinney knocked on my door. She is, without a doubt, the most important researcher in the world related to causes of SIDS, and I knew her. And she said, "You want to do something?" And since that time, I have increasingly dedicated myself to this problem and to all the different aspects of it.
Well, first of all, thank you for what you do, because you're with families at their most difficult, challenging time. And I can't imagine it's an easy role to fill, but a very important one.
I think there's a lot to be said for being a doctor that's willing to stand in when everyone else would really just as soon not be there.
As a neonatologist going through my training, many folks even said, why would you go into that? Because we do have a lot of loss. And it's a very hard thing to deal with, but it's something that I think draws people that really care and are willing to be there in those difficult times. And so just very appreciative of what you do, because I'm sure it's not easy.
Well, thank you.
So as we dive into this topic, can you tell us just in general, what are the numbers of, sort of children or infants that pass annually in the U.S.?
This is the first century in recorded history where the death rates in children are lower than adults. The fact that death in children is so rare really points to tremendous progress. Some of that's public health and some of that's medicine. About 37,000 children die each year in the United States. And after all the diagnostic efforts to understand it, 10% of that remains unexplained, right?
Wow. When you think about it that way, it's really daunting. That
it's a lot. And when you think about SIDS, or sudden unexplained infant deaths, there's really no condition beyond just the newborn period that has such a high mortality rate throughout childhood.
Who's at risk of sudden death?
Most people and many doctors think that this is kind of like a sleep accident. It's, if we're talking about SIDS and SUID, that it's a sleep accident, and they imagine that it's suffocation. And what's important to remember is that this is not suffocation. And all the sleep advice, make sure that the surface is clear, no baby bumpers, really minimize soft blankets and soft animals. Place your babies in the supine position. Those are addressing risk factors, but not necessarily the cause. So right now, more babies who die from SIDS are placed in the supine position than are placed in the prone position.
And just so our audience knows, supine is when a baby or anyone, a person, is lying on their back.
Sunny side up.
Sunny side up, yep. And then prone is when you're on your stomach. So
yeah, on your belly.
On your belly, yep. Okay, good. Just in case anyone wasn't sure.
So a couple of other factors. If you are a black infant, you have more than twice the rate of white infants. Oh. And by the way, that gap is getting bigger. If you have a child that dies from SIDS, you have a greater than 4-fold increased risk of having another child to die from SIDS.
Oh my
and if
goodness.
we go through 3 generations of your family, it's almost 10-fold, 9+ fold increased risk. And that drives us to try to find genetic reasons for that. And that's what Robert's program is really constructed around. Sudden, unexpected deaths. They occur suddenly, they're surprised, and unexpected, and most of these children don't have any medical condition.
No previous, yeah.
There's no reason to have believed that they would die during that sleep period. So parents put a well baby to sleep, and they discover them dead. A parent's worst nightmare. And a world's worst nightmare, really. I think everyone shares in what a terrible gap it is, that not being able to identify and understand what happens.
So you talked a lot about those kids that we don't have an explanation for. But what are some of the things that kids die from that do have explanations?
So a huge amount of pediatric death occurs in NICUs or to newborns. I don't know what that statistic is, but it might be 50%.
I should know. Yeah.
Yeah, it's large, and it's prematurity, it's congenital anomalies. I think that those are the 2 leading contributors. You would think like the babies that don't have a successful start die, and then the rate would kind of slowly go up through life, but that's not the mortality curve. The mortality curve is to actually decrease until 10 and then go up again. And when it goes up again, it's things like homicide, suicide, firearms related stuff.
For any child that dies, whether it's, sort of potentially expected, maybe a child with cancer or who's faced a long time chronic illness, or it's completely unexpected, as the cases that you're talking about. What I can't imagine that the grief that a parent experiences is got to be the hardest thing to do. You have cared for so many families. What are some of the things important for people to know about grief for parents who have lost a child?
The death of a child shakes your place in the world. We have a sacred duty to our children, a sacred obligation that's beyond any question. And their child has died. And even in cases where the explanations are clear and we can point to a disease, it's very hard to separate yourself from that and to not worry that you had something to do with it. We've studied mothers after SIDS, and one thing that we see that's especially prominent is something that we call role confusion. And by role confusion, it's really a private question that these mothers and fathers also are asking themselves, and that is, who am I if I can allow my baby to die before me?
Oh.
It's a tremendous burden. If there's a parent out here that's listening to this who who's gone through this experience, I'm not telling people the way they ought to feel. And there's no way that I am capturing with subtlety
or the breadth of
what an individual goes through. But I do think that there's a very scary time when your child dies where you lose your connection to them and you don't know how you're going to regain it. And it almost creates a kind of sense of panic in yourself. We see this when we're walking people out of the hospital after they have to leave their child, after they've died. I think parents have been through it will have a sense for what I'm talking about, and otherwise people wouldn't necessarily understand how terrifying it really is. We try to help them regain and then sustain that connection, because the connection's never really lost, and there are aspects of the child that are forever.
It's just really interesting that you, having, cared for and studied so many families, understand that, because, for me as a clinician, I for sure have struggled with, how do I support a family in those moments after their child's passed, right? I mean, I feel like I spent so much of my time focusing on how to support them up until the point of death. But then it's even less known how to support them after. And it's really helpful for me, and I'm sure for anyone who knows someone who's gone through the loss of a child, to understand that there is this panicking of losing that connection with your child. I could see how that must be very scary to leave the hospital or separate.
The role confusion is rooted in research that we do in something called prolonged grief disorder. That's an attempt to understand who is most at risk for a bumpier adaptation. Mm-hmm. It's an adaptation. The goal here is that the pain won't go away, but you find a place for it, that you regain some sense of connection, and also that you're able to reinvest in relationships, you're able to have a good day and not feel that you're betraying your child. It's a hard thing, and it's hard in different ways at different times.
Wow.
I think in the beginning, there's nothing that you can say, and there are things that you can do, but there's really nothing that you can say to make this better. Yeah. I think presence is important. I think protecting people is important. I think rescuing them when they're trying to go out into the world again in those first tender days after the loss is important. I think it's really important just to do for them. All these well-intended people say, just tell me what you need and I'll do it.
Yeah.
And they also have friends that just do it. And or they say the child's name and they don't
shy
away from that. And they help them mourn in a healthy way. And if you think about what we do in other contexts that don't seem so sad, is we remember the child, and we remember the beauty that they brought into the world and their own unique qualities. And somehow that feels, we're worried about that. And we're worried often because we think we're going to hurt them.
Make them sadder, right?
Make them sadder. You're not going to hurt these people because they have been as hurt as you can get.
I think that's really helpful to have learned from you, is this idea of keeping that child's name, memory, essence alive, and not to shy away from it. So for anyone who's listening and knows someone who's lost a child, to feel like that is okay. It's the right thing to do. It's, probably what parents need to hear.
Yeah.
Can you expand?
I think that happens in many ways. One time that it happens that's especially worth talking about are holidays, birthdays. The death day is its own thing, and I think that there's a lot of variation in what people feel that they need to do. But it's really important for parents who have imagined a life of happy family celebrations to feel that that child who is not physically alive is still present in those things.
Part of it.
That can be an ornament on the Christmas tree. If the child had a favorite stuffed animal to just have it on the table. It can be some kind of a recollection instead of an absence when people talk about all their grandchildren or all their children so that their name is stated. There's a way that you can do that. Again, it depends on the individual parent and what they would prefer. Many people are very private or they're too fragile, so that would be threatening. But I think it's nice to keep the memory of the child alive, to hear their child's name. And it's nice to hear their child remembered because there's an exceptional kind of strength that these parents have just going to whatever, going to the birthday party of a baby that was in the mother's group.
Yes.
Going to Thanksgiving.
With family.
With family, yeah. And they're not looking for credit, but it's nice when it's recognized. It's nice when it's recognized with soft gestures, I think.
It sounds like one of the most important things you can do is to support in keeping that child's essence alive.
Yeah.
You know, even if they're not here physically. So you mentioned anger and panic as sort of, you know, not uncommon reactions or emotions after losing a child. Are there other emotions that, you know, sort of loved ones should be on the lookout for?
So particular to the children and families that we deal with, because of resuscitation, because of the scene, it's often quite traumatizing. And those memories may be really distressing to revisit. And what's difficult is that blocks access to your last moments with your child. And so that's traumatic. Grief is not depression, but this can be really sad and people can get really depressed. And if you are depressed, your experience with grief is more difficult. And then as part of more complex grief can be things like difficulty moving on, a sense of meaninglessness in life, a kind of this kind of anger or sense of bitterness, these sort of crushing emotional pangs that people sometimes feel, and deep yearning for that child that's not there anymore. And that can be a little baffling, I think, to a lot of people to understand just how this can be normal, part of healthy coping. Those aren't all the symptoms are there. Those symptoms that I'm talking about don't have to be disabling. When they're disabling, then we're a little bit more concerned about it.
And that's a whole array of emotional responses and challenges that parents are going through.
Grief research is based on attachment theory, taking care of your child and making sure that they can depend on the world, and how important that is to your sense of who you are, and to understand then that gets severed. All those pieces to it then come into play. And I think that speaks to the complexity of the experience.
And I would imagine that also impacts a mom, a parent, at any age that a child's lost.
Yes. When you're a parent of a younger child who is so dependent on you, it might be a little bit, the wound might be a little bit sorer, but no one is exempt, I don't think.
Can you tell me a little bit about the 4 stages of grief? And I know you've studied this a lot.
So culturally, when Elizabeth Kubler-Ross wrote her books, it was a major contribution because we're a death avoidant society. Most of it had to do with observing people who were coming to terms with their own terminal illness. What it's evolved into is this sense of that there are stages people go through in healthy grief. And what that does to the bereaved person is it creates pressure. Well, I'm still in denial. I feel too much anger. Is there something wrong with me? And where we especially see this with parents, with bereaved parents, is this idea of acceptance. Because why should they ever accept the fact that their child's not here? And in fact, they show their dedication to their child by, pushing back on that.
Like
and
not accepting it.
Exactly.
Yeah, it's not
exactly.
okay.
We studied 400 women for 3 years after their babies died from SIDS. And when we asked them what they thought about acceptance, it actually kind of made them mad that we would even expect them. It felt like a little disrespectful, a little failing to understand things. So let me just talk about the pathologic part. If you're an elderly widow and your life partner dies, about 10% of the time, those people have troubles learning to reinvest in new relationships. They have troubles allowing themselves to have a good day. And they really kind of struggle with finding meaning aside from the meaning of being dedicated to the loved one's memory. That's 10%, according to the Yale bereavement study. In our population of mothers after SIDS, at 1 year, it was 60%.
Wow.
And at 3 years, it was 40%.
So you're saying that parents who lose a child are exceedingly more likely to have what you would consider a pathologic or a maladaptive transition?
Well, that's why I really
Grief.
don't like the pathologic framing,
know,
because
I
it's
know.
so normative.
Exactly.
But I think what it says to me is that this is a life event that is very hard to cope with. By the way, that 60%, that's normal, right?
For parents.
That's a normal
lose a
part
child.
of it.
Yeah.
We have to remember that as it presents itself. Family members, especially well-intended family members, feel sometimes like, I kind of wish you would move on. I kind of don't like to talk about anything with him because it always gets around to their child, or I'm always worried about hitting a sore spot and seeing them get sad. It becomes inconvenient to deal with these parents who are hurting,
Yeah.
who would be expected to be hurting.
Normal process of the grieving.
And it's normal.
But it's hard for others to almost cope with or deal with.
It's hard for them to tolerate it, really.
Yeah.
And so I think that's an important signal to us all that it's on its own timeline. If we're really worried about someone, they should maybe get some help.
Yep.
But no one's on a clock. I sometimes have the grandparents come and talk to me about just how hard it is to watch their children go through this, let alone deal with the death of their grandchild. Some of it's just normal, healthy adaptation that gets them out of it. And occasionally, if someone's really having a hard time, then we have to do a little bit more to help them.
And that is that the prolonged grief that you were mentioning?
That would be prolonged grief disorder.
Can you just define it for us again, that prolonged grief? How would you know?
Depending on which criteria you use, I'll use the more conservative. Whatever symptoms a parent presents with that are grief-related, after a year, if they are disabled by pangs of grief, emotional pain, if the yearning just crushes them on a daily basis, if they are really troubled by this confusion about who they are and how they stand in the world, if they're troubled by anger, if they're lonely, if they feel overly isolated, and there are a number of other symptoms for that, then that's someone who probably needs professional help.
It's important not only for caregivers, professional caregivers, to know when someone might need referral if they already haven't sought help. Important for them and, family members to be able to say, this is important.
Young families who are well supported have a tremendous capacity to heal and to find a way where they can manage these feelings and live with it.
Thinking back to Ryan, our parent, who had the question of, how is he and his wife going to be able to cope with this horrible situation? What things or how do you recommend we support families?
The first thing I would say to Ryan and his wife is that couples don't deal with it in the same way. On a couple level, they have to learn to help, to really look out for each other, to not be disappointed, to open up lines of communication. I often think about getting out of bed in the morning, and I think it's one thing that people don't often talk about is that grief is a physical affliction. People feel sick. It is hard to get out of bed. They don't feel good, and they really don't sometimes want to get out of bed. And so couples, I think, help each other by checking in and maybe not solving, because I think that's too much to think you can solve your partner's grief that day or whatever. But to reduce the sense of like going through it alone, not being able to talk about it.
So communicating, really.
Communication, like relational coping.
Yeah.
Like not seeing that it's one, you might be dealing with it differently than your partner, but you're in it together.
Yeah.
And that involves tolerating big difference.
What about siblings? Because I can't imagine that this doesn't impact them. Is that a tougher question?
Well, it's just a complicated question. Many of the children we take care of in the hospital, if it is a two-parent family, one person might be in the hospital for huge amounts of hours, another might be at home, and that same person at home might be the breadwinner, and the kids can get shuttled around.
Yeah.
Parents worry that the other child's death or the other child's illness is going to hurt the other children. And so I think it's good for the caregivers to acknowledge all this effort. It's important to understand the family units and how they work.
That's important advice.
Research that I'm aware of that looks at other siblings and asks them what the lessons were that they learned in seeing their parents go through this. The lesson is usually that they understand how much their parent is willing to do for the love of their child, and they don't feel exempt from that, but they feel a participant in that. Their family becomes richer and deeper and more appreciative of simple things like tomorrow. For me, that's a privilege to watch.
I just think that's such a beautiful sort of piece to think about, and hopefully for our audience to hear that in this most unnatural situation, that there can be gifts to that family.
It reveals a lot of things.
As the human spirit.
It's a pretty ugly tangle, but I think what I'd like to emphasize is the strengths that are revealed.
That's amazing. I did want to say, you mentioned something, or I've heard something about this dual grief process, or process of process of grief.
And Schutz's dual process of grief.
Yes.
Yes.
Can you tell us a little bit about what that is?
What these researchers propose is that there's a dual process. Some of your time after a loss, you need to focus on the loss and all the feelings that it provokes.
Lean into it. Or
be captured by it. It can be passive. Like in the beginning, you're not in control, but it's called loss-oriented behavior.
Wow.
But also, there's another side to that, which is more restorative thinking. And that's a friend comes by and you have a cup of tea. That's someone remembers something silly that you forgot. That's you finally get yourself to go through the child's room and you pick up their blanket and smell it and you feel positive, mixed but positive. And it's not an either or thing. It sort of goes back and forth, and one side informs the other. And in the beginning, the loss orientation might really dominate your thinking and your feeling, and the restorative part might be less accessible. But the thinking is that over time, they entwine and they become a little bit closer together, not on a timeline, and also to live with the loss, not to be overwhelmed by it, but to find a place for it. It allows your memories to evolve, allows your relationships to evolve, and that's all embedded in this dual process.
It's sort of that combination where hopefully over time it sounds like, you get to where it's interweaved, but it's like a balance. There's both. And one brings you restoration to keep you going, and then the other one, sort of helps you hold on to that sacred loss that you've had.
I did some research on something that I called transitional objects of grief. When babies are dying in the NICU, we bring out the handprints and we take pictures, photos, and all this, and we give it to them thinking that it's
something they can hold on to,
and that will be helpful.
Called memory making, yeah.
Memory making. But what I found in my research has something less to do with being given memories and more to do with what's called transitional objects. The classic transitional object is that blanket that your kid loves. And, they physically mangle it and take it with them everywhere. But somehow the child chose that, and somehow it became precious. These objects emerge. They're kept. They emerge as important, and they carry characteristics of the child who's absent.
Well, and the child chose that.
The child chose that. I did another big study on SIDS mothers, and they basically all have a box. They have things that they kept from their child. And the majority of them visit them at least once a week, and they have very private but precious moments with them, not because they were given, but because they were precious to them. And sometimes it might be the footprint that's in there, but sometimes it might not. It might be, who knows, the favorite onesie or something like that. I think what happens is we sort of stumble our way into ways of keeping the child's presence alive, but it's a very complicated experience when it does. And what you see in these parents when they're accessing these kept objects of the child is that it's sad or it's happy or it's not an emotionally neutral experience. They're no longer objects, and that ends up sort of encapsulating what grief can be. It can be precious. It can be affirming of how important that child was, how every little thing about that child was. A pair of socks might just remind you about their toes. And there is something really sacred about those moments.
Wow. Oh my goodness, that taught me a lot. And you think about, I'm just processing all that you've just shared. That memory, that box sounds like it's their way of connecting with their child in a very physical, concrete way when they maybe can't physically hold on to their child.
Yeah.
So Dr. Goldstein, you've shared so much about how we can support if we know someone who's lost a child. Well, I wish I'd met you before I tried to help a friend through this. And like you said, it's not over, so I can still take these lessons learned. With all of the knowledge that you have, how does the Roberts program help families?
The population that we deal with are children who die without explanation, and they have a fairly unique experience, kind of bad experience in America, but across the world. On a psychological level, anything that remains unexplained invites any possible idea or reason, including high amounts of blame, self-blame to it. I think that there's also societal blame. So the fact that there aren't answers and explanations, they just won't give themselves a break. We add to that when any child dies without an explanation, it becomes a medical examiner case, and that is not the normal process. So when a child dies in the hospital of a known disease, we spend days, hours, so much time helping the parents anticipate what's going to happen. And when the death occurs, we invite all the support in the world, and it's a little bit more gentle than what happens when a baby dies in their home. Someone calls 911, EMTs come into the house, they trundle in and they do resuscitation in the home. We were talking about siblings. The children see their parents utterly crushed and horrified. You have that. You have police presence. The standard procedure is to separate the parents because first responders hit the home. They don't know if this is foul play or not. If they go to an emergency room, social services is called. Their access to the child is limited. They have to ask permission whether they can hold their child after they've died.
Oh, that's heartbreaking.
Often the child's taken away and they end up at the city morgue.
Mm.
Then they're interviewed.
Looking for
right, and we can all understand this.
Yeah.
But what a difference it is between what we imagine would be a better way of dealing with it. Whether that was the case or not, when we're trying to explain something that's happened in a child that's already died, it is impossible for us to get the kind of information that we need in a medical history without stirring big, strong feelings in the parents. And so from the beginning, we've been very respectful of the state that they're in, and we've tried very hard to build a program around what we understand there needs to be at that moment. Robert's program is a clinical service that it's really an undiagnosed disease program. We're looking for rare and inapparent diseases in this children. So it's a clinical service that's available free of charge to families anywhere in the United States. The child's died suddenly and unexpectedly, and no one has figured out why they've died. And we try to find the reasons for the death, but we also try to help them adapt to the death. That's the word we keep coming back to. Mm. We have 3 questions that really provide structure to what we're trying to do. Parents want to know why it happened. Was there anything that they could have done to prevent it? Is there any way they could have known? Is there anything that they should have done? It's very hard, but sometimes the kid had a cold and they thought about calling the pediatrician, or they did call the pediatrician and the baby died that night. Or they always wondered about something that they were reassured about, but it really bothered them. Or they never got around to talking about the cousin with epilepsy. Sometimes that's really painful, but I feel like what I want to promise them is that they're going to know as much as anyone can possibly know about what happened. And I want to honor the fact that this is an act of being a good parent to try to figure that out.
Just like you would for a child that's alive.
That was alive. Exactly.
You would be searching every single detail.
Exactly.
If there was something going on with your child and want to know it all and seeking all of that out.
That's right.
And I imagine if you can't provide those answers, that's going to be a constant question in their mind.
Well, it presents itself in different kinds of ways.
Yeah.
One is this idea that their child was let's use the phrase, ticking time bomb. Oh. And what a terrible thing to think. The idea that somehow it was preordained that this was what was going to happen, and the threat of that just swallowing up everything else that was important about that child's life. Wow. The second thing is there is value just because families may go on to have other children or whatever, there is value in being able to say, well, I can't tell you what happened, but let me limit the scope of what might have happened. Because in fact, all these people that had heart attacks on the father's side, we looked at all the known genes that are related to cardiac arrhythmias, and we don't find them. And so we don't think that that played a role here. So if within your family you're thinking about that, I can't reassure you 100%, but I think that's one that you probably don't have to worry about as much. In the era of genomic medicine, where people think that everything has an explanation if you could just figure it out, it's good to wade into those waters and try to help people with it. And that actually gets to the third question, which is, what does this mean to our family right now? What's the impact on the siblings? Do I have to worry about risk?
Are they at risk?
And does anybody need further testing or further monitoring? And so we try to provide all that within our program. We have an extraordinary group of doctors and researchers dedicated to the problem for now 12 years. In our hospital, we have never asked a doctor or a division for help when they didn't bring their best with unlimited resources. So, and that's a privilege, but it also speaks to a strength that we have. So we have doctors in genetics, neurology, epilepsy genetics, cardiology, metabolism. We have a specialized pathologist who looks under the slides at all the general anatomy from the autopsy. That's because we don't have a child to examine. We have someone that's dedicated in investigating the brain. I don't know, I'm really proud of it. It's sort of unparalleled.
You're bringing together experts in rare diseases and things that could affect any single body part, and you're bringing them all together to really help with a fine-toothed comb.
By definition, we started with children who didn't have a diagnosis, so zero. Zero were understood. Now, over 10% of the time, we find a genetic explanation. Sometimes cardiology, sometimes neurology, sometimes just complex multi-system syndromes. About, up at least 30% of the time, we find something on pathology that indicates a disease process that was, if not the cause, absolutely involved in it. And we go through the family tree. We can talk about how this disease or this gene might have shown itself in the family. We give them a plan of what to do in the future. And we spend a lot of time trying to understand about the best way to take care of them emotionally.
For those families where you don't find the answer, which sounds like, that's still a lot of families that don't end up with an answer, I would imagine there's some benefit to knowing that we looked for everything we could.
I think that honors the child. It honors them as parents. And it's a kindness. We really care about that.
So you mentioned with the Roberts program that not only do you have all these experts clinically to help, uncover answers, but that you also provide emotional support. So do you also have psychology or other similar members of the team?
We have a genetic counselor, emphasis on the counselor side, so she's exceptional. And then we have a psychologist who's expert in bereavement and whose mission is to elevate the game of how to respond to child loss in sudden unexpected deaths. We have not siloed anything, and we believe that one piece speaks to the other. And it's all, as I said, built around what we understand the parents' needs to be.
Caring for the whole family. Are there any other resources that maybe parents could go to help get more support?
So there are national SIDS organizations, and they run some groups, and they also can make referrals to different kinds of groups. Our program tries to offer things. I think all those are helpful. Many families that are connected to a faith community find great comfort and understanding by relying on those communities and the supports that they can bring. And then some people are having a harder time and probably would benefit from speaking to a psychologist or a psychiatrist. And that doesn't have to be that there's something wrong, but that can just be attending to the fact that this is a really hard thing to metabolize, to make sense of, and to learn how to live with. And I think especially for people that are burdened by private struggles, that can be really helpful.
That makes sense. We don't talk about, so we don't necessarily have any knowledge of how to go through this type of a life altering event. So it makes sense to seek out help.
It's a real vulnerability, and it shouldn't feel stigmatizing to ask for help.
I agree. Unfortunately, it seems like all too often it is, but it's like when you skin your knee, break your ankle, you're going to go to a doctor. This is something that makes sense. I am sure you're helping so many families listening right now. What's on the horizon for this field? What research is your team looking at?
We have a long way to go to understand what's particular to child loss. Our research only documents the fact that this is so much harder than other kinds of losses. And so I think that in the world of grief research and grief support, we can try to understand things a little bit better. We started this conversation talking about, children dying in their sleep in the prone position. And if you look at childhood, sudden unexplained death in childhood. Not
infants.
SIDS, but 1 up until 18. Those children they also die in their sleep, and they're found in the prone position. And if you look at sudden death in epilepsy, so some patients with epilepsy die in their sleep, they too die in the prone position. And then when you go into the research that we've done, we actually find the same epilepsy-associated changes in the brain and the same genes with mutations in them in all 3 groups.
Between like the
sudden death and epilepsy, SIDS and
SUDC. And SUDC for children.
Yes. In fact, that's why we call it Robert's program in sudden unexpected death in pediatrics, because we don't really think that those age distinctions really make as much of a difference.
Wow.
So there are great opportunities within the field to strengthen epilepsy research, but also to bring the strengths of that to unexplained deaths in children. And then ultimately, we want to identify them earlier. Newborn screening is getting increasingly genetic. So there are many things that we're trying to develop to identify these children earlier and, where possible, prevent the deaths.
So a lot more work to be done.
A lot to be done.
But you've also made a lot of progress thus far.
Yeah.
Well, as we wrap up, is there anything that we haven't talked about that you want to make sure our audience knows or learns about related to unexpected death in children?
Give some thought to how isolating how isolating and kind of disappointing this can be for the parents that are going through it, and to find their own individual ways to try to break that down.
And not being afraid to keep the name alive of the child.
Yeah, small kindnesses really matter, especially in those early, crushing, difficult days.
Bringing food and...
Just do it.
Just do it. Don't ask. Just do it.
Just don't do it. Just do it.
I love that. So now it's that time of the show where we do doctor's orders.
My doctor's orders are to believe that there's a time where your child will be present in the world and that you can live in harmony with this terrible loss. And to everyone else around them, don't ask, do. Say the child's name and admire their strengths and help them.
That's a very good prescription. Thank you, Dr. Goldstein.
Thank you for having me.
Thank you so much for joining us for today's podcast. Special thanks to our parent, Ryan. Know that we are sending you lots of thoughts for support and comfort during your grief journey. And thank you to Dr. Goldstein, our guest expert, who provided us so much information on how to support others going through the loss of a child. See you next time.